Good morning. I'm Dr. Melissa Arbuckle. I'm the Vice Chair for Education, and it's really my pleasure to introduce today's speaker. Before we get started, I just have one announcement, and that is about next week's Grand Rounds. Next week's Grand Rounds will be one of our own, Cristiani Duarte. She is going to talk about how can we break up the cycle of childhood adversity, learning from the Puerto Rican youth growing up. And today's speaker, I think it's always a treat when we have our own faculty presenting. It's really a nice opportunity to hear the wide range of things that are happening here at Columbia. I think it's a nice extension of yesterday's event, which was the poster session at the Vagilo Center, to really see all the things people are doing. And today, I think, is going to build on that. So Dr. Remien is today's speaker, and his talk is going to be on the arc of the HIV epidemic and the key role of mental health in efforts to end the HIV epidemic. He is a professor of clinical psychology and director of the HIV Center for Clinical and Behavioral Studies here at the New York State Psychiatric Institute and in our department. The HIV Center has multiple institutional partnerships with Infectious Disease and Medicine and the Mailman School of Public Health at Columbia, Albert Einstein Medical College, Hunter College at CUNY, and the New York City and the New York State Departments of Health. It comprises over 150 researchers and staff who represent a broad range of disciplines, including developmental, community, and social psychology, biostatistics, ethics and public policy, epidemiology, anthropology, psychiatry, psychiatric and pediatric and adolescent medicine, and community outreach. As a researcher and a clinician, Dr. Remien has had considerable expertise in the development and implementation of interventions designed to improve HIV care and mental health and reduce the sexual risk among vulnerable and disadvantaged populations. He has conducted behavioral research in the HIV Center for over 30 years and has been principal investigator or co-investigator of federally funded grants focused on the medical treatment access, improving HIV care, the doctor-patient relationship, adherence to HIV care, and mental health coping with HIV-positive individuals. He has been involved in clinical work and community mobilization and advocacy since the early 1980s. He's the clinical director for the mental health in the Northeast Caribbean AIDS Education Training Center, faculty mentor for the HIV postdoctoral fellows, and serves on numerous NIH review panels and local, national, and international advisory groups. So please welcome me and please join me in welcoming Dr. Robert Remien.
Thank you, Melissa, for the nice introduction. It's great to see everyone here. It's a pleasure to be here. I know this title is a mouthful, but I am attempting to cover many issues and many bases in this talk, so I hope you'll bear with me on this journey. But at the heart of this talk, which I trust that all of you can relate to, is the mission of the work that we do here in psychiatry. And as I wish Jeff was here, as our director, Jeff Lieberman, said in his New Year message to us all, and we're still in January, so I figure I can quote this. He said, "The start of a new year is a time to pause to view the bigger picture and the role we play in it. In this context, we can appreciate the importance of what we contribute to society and humankind. Through scientific research, we further that capacity of psychiatric medicine and mental health care to make real and tangible differences in the lives of our patients." And Jeff went on to ask that we continue to advance our mission and at the same time be more sensitive and more compassionate to the needs of others, and particularly those with mental and substance use disorders. So it's in this spirit that I would like to share with you the work that we do for the people affected by the HIV epidemic. To give you a little bit of a roadmap of what I'm going to be talking about and the key takeaway messages and points, through the arc of the HIV epidemic, we have actually, I feel, come full circle in terms of the need to focus on mental health, including substance use and addressing the epidemic. Early on, it was very much about the history of past conditions, history of mental health and substance use problems associated with populations vulnerable to acquiring HIV, and dealing with communities coping with stigma, discrimination, and multiple losses. Now it's very much about the role of mental health and our ability actually to end the HIV epidemic, because today mental health plays a central role in HIV acquisition as well as influencing behavioral and health outcomes in HIV disease. I hope you'll be convinced from what I present that there's a need to integrate mental health and substance use screening and treatment into all HIV care settings. And there are models of integrating mental health care into HIV care that can be applied to other domains of primary medical care. And to get those messages across, I'm going to give you a little bit of history of the epidemic itself and key moments in the arc of the epidemic, the origins of our HIV center here at Columbia, the need for multidisciplinary collaborations, talk a little bit about the contributions of our center to the larger field, and what's happening today in terms of ending the epidemic initiatives and the centrality of the role of mental health. And then talk about the HIV Center and what it looks like today. And part of that is hope that some of you who are not affiliated with the center might think about being affiliated and collaborating in partnership with us. So let's go back in time. Here you see in 1981 the first report of 5 cases of a disease among healthy gay men in Los Angeles. And then 2 years later, a month later, from June to July, 1 month later, the New York Times first reported on the largest sample of this group, this population dealing with a rare cancer. So to keep us placed in time, in 1983, the virus was first discovered. So that was 2 years after discovery of these illnesses and these deaths. The antibody test used to detect HIV was approved by the FDA in 1985. And by 1995, complications from AIDS was the leading cause of death for adults 25 to 44 years old. The HIV Center began here in 1987, just 4 years after discovery of the virus, and right in the middle of the dramatic upswing in the number of deaths from AIDS, which as I just pointed out, peaked in 1995. Here you see the founding HIV Center Director, Anke Ehrhardt, and the 2 co-directors, Bob Spitzer. Many of you work with him, and most of you know him as a leading psychiatrist in the field. And Zena Stain, who is a world-renowned South African epidemiologist from the Melman School of Public Health. On the left, you can see the article in the New York Times announcing the start of the center, announcing that it was a $19 million funding from NIMH, which was the largest single award ever made by NIMH at that time. The HIV started as a P50, which means it has a lot of cores of infrastructure and several projects. I don't have time to talk about all the projects, but I wanted you to see the breadth of the science cores we had in the center in the beginning and how truly multidisciplinary it was. You can see across psychiatry, medicine, infectious disease, public health, neurology, and sexual behavior. I'm going to focus a bit on the work that came out of the psychiatric psychosocial core, led by Janet Williams with Judy Rapkin, who is here, and Richard Neugebauer and myself.
Can we see that again?
Not a bad picture. And none of us have aged at all. I'm going to talk about what I'm calling 3 phases of the arc of the HIV epidemic. The first phase being focused on understanding HIV pathogenesis, of coping, survival, and of course primary prevention among populations vulnerable to acquiring HIV. The second phase, meaning the behavioral, social, and structural challenges of access and adherence to a new effective combination therapy, or ART, antiretroviral therapy. And the final phase, which is the phase, not final, the third phase, which is the phase we're in now, is ending the epidemic through implementation and scale-up of advanced biomedical strategies for HIV treatment and prevention. During the first phase, this is what we were dealing with. People coping with opportunistic infections and progressive illness. There were no effective treatments for HIV. Doctors were treating symptoms and opportunistic infections, and patients were using experimental therapies with the hope that it might make a difference. And this went on for many years. And people were shunned by family and friends and feared by the public. Some hospital workers refused to enter hospital rooms of AIDS patients. There was a lot of fear, stigma, discrimination, isolation, secrecy, and suffering. Ryan White, who was diagnosed at age 13 with AIDS following a blood transfusion, fought heroically AIDS discrimination in his school. And famous people like Rock Hudson were secretive about their illness. There was indeed a great deal of suffering going on. And there was multiple loss and decimated communities, both globally and locally. including, unfortunately, we lost people within our own center, and for some of us, many people in our own personal networks. So here are the domains of research focused early in the HIV epidemic that the center was engaged in, with just a few examples of the publications at the bottom. I'm going to apologize right off the start because there's so much research that came out early on. There's a lot of research that won't be represented here and highlighted, including from some people in the room. But we were highly focused on improving health and psychological outcomes for people and families coping with AIDS, identifying the correlates of risk and illness progression among populations most at risk, which at the time was gay men, injection drug users, heterosexual women, children and families, homeless population, and people with chronic mental illness. We were starting to focus on developing and testing HIV prevention interventions and studying vulnerable youth for prevention, developmental stages, and cognitive functioning for youth living with HIV. We also studied correlates of AIDS long-term survival in a large longitudinal study called and also in a large follow-up study, we examined the natural history of HIV disease among cohorts of gay men and male and female injection drug users across these domains in terms of psychiatric evaluations, neurological, medical, and sexual behavior. Here I'm choosing to focus on some of our psychiatric findings that informed the field at the time, since our center was really the first research group that conducted such rigorous psychiatric assessments among people living with HIV and having HIV-negative comparison groups recruited from the same population. We found that there were very high rates of lifetime major depression and alcohol and other psychoactive substance use disorders compared to the general population norms. However, we found low rates of current mental disorders, high levels of hope, low levels of current depressive symptoms. Depressive symptomatology was not related to number of AIDS losses, interestingly, and we saw a significant decline in the rate from lifetime to current of alcohol and other psychoactive substance use disorders. Similarly, in our injection drug using cohort of men and women, we found that prevalence of diagnosis of current depression and severity of depressive and anxiety symptoms in both positive and negative IDUs were greater than in the general population, but not greater than in other studies of injection drug users. The rates of psychopathology found in the IDU cohort were independent of HIV status as well as gender. So overall, we saw high rates of depression across HIV status in this cohort, suggesting that intravenous drug use and associated factors are more salient than HIV illness factors in understanding psychopathology in the population at the time. In collaboration with Gay Men's Health Crisis, which was the largest community-based AIDS organization in the country at the time, we conducted a study of 53 AIDS long-term survivors. These were people who were told they had only months to live, but were living for 3 or more years after being given that news. We found that there were low rates of current syndromal mood disorders and psychiatric distress, and participants emphasized the importance of taking personal action with regard to their medical care, reevaluating and modifying goals and relationships, being involved in the community, and pursuing pleasurable activities. All of this what I would label as positive coping. And they talked a lot about finding the right doctor to work with. Many of them changed doctors to find a doctor they could work closely with. This led us to conduct a large qualitative study of the primary care providers of these long-term survivors, because the survivors spoke so much about the importance of finding and working with providers with whom they can engage and work very hard and aggressively at fighting their illness. And we wrote this book called Good Doctors, Good Patients, Partners in HIV Treatment. So, in terms of treatment of HIV disease, there were 2 important discoveries in the 1990s. First was that AZT was seen as not fully, but highly effective in preventing transmission of mother to child of HIV. And this was really just simply about giving one antiretroviral medication to women just before delivery, during delivery, and after delivery to the baby. And it was effective. It was the first time we saw some efficacy in preventing HIV transmission. But what was really dramatic and really transformed the field was in 1996, we came along with what's called combination therapy, known as HART or ART or CART, 3-drug therapy, which at the time reduced AIDS-related illnesses by 50%. So this really But what we very quickly saw, and it was very quickly recognized, that there was a need for extremely high levels of medication adherence for therapy to maintain efficacious, since the virus was able to develop resistance with even minimal lapses in adherence. So I think, as all of you know, near perfect adherence to any medication in any disease and any chronic illness is not what humans do. So getting people to 95% or better was really, we're just working hard at really trying to do that, because the resistance developed so quickly and people would start to fail on what was very potent treatments at the time. Treatments are much better, and I'll get there. This led to what I'm calling the second phase of research and care in the epidemic. It was very much about access to these highly potent therapies, dealing with disparities globally and locally, aggressively treating people with HIV, particularly with illness, and bringing awareness and knowledge, and dealing with people's attitudes and their willingness to start or unwillingness to start the medication. There was a whole pendulum swinging back and forth in terms of guidelines and advice about when people should start antiretroviral therapy. Patients and providers were concerned about long-term toxicities. So it was a balance or a question of, do I withhold the medications till the immune system is more compromised and the CD4s drop, or do we initiate therapy early? And that pendulum swung back and forth for many years. But for anyone who was starting treatment, it was about adherence, adherence, adherence. We're examining the behavioral, psychosocial, structural barriers and facilitators of adherence, and starting to develop interventions to achieve optimal adherence, and developing and testing these interventions. And of course, throughout all of this, our center and researchers, now around the world, we're still dealing with ongoing primary prevention, both among HIV negative and HIV positive individuals, to prevent transmission of the virus. So I'm going to jump to the past decade, which ushered in our current third phase of research and care. There were two major scientific breakthroughs that happened in this past decade. PrEP, which is a single pill a day for a two-drug combination of antiretroviral therapy, amitriptyline and tenofovir with the brand name of Truvada, many of you may know it as, to prevent HIV acquisition, and treatment as prevention, which essentially is the recognition that a person living with HIV who is adherent to his or her medication and achieves and sustains viral suppression is unable to pass the virus to his or her sex partners. This was the first study showing the efficacy of PrEP, although there are now additional studies supporting its efficacy in preventing HIV acquisition. In this trial, overall, PrEP reduced the rate of new infections by 42%, which was dramatic at the time. But when you look more closely at the data, those with blood levels of drug equal to 7 days of dosing per week, in other words, taking that one pill a day, had an efficacy of 99%, which is dramatic. And then 1 year later, a large definitive study ushered in what we call treatment as prevention, showing that if an HIV-infected person adheres to their ART, the risk of transmitting the virus is reduced by 96%. And I'll talk more about this later, because now the efficacy is seen as nearly 100%. The few infections that occurred in this trial, which was done with HIV serodiscordant couples, occurred because either the HIV positive partner was not fully suppressed at the time, or the HIV acquisition was from an external partner from the relationship. So in other words, if people really are suppressed, we're talking today about there being nearly 100% efficacy at preventing transmission. So this paper was deemed by the journal Science to be the scientific breakthrough of the year. This led to mathematical modelers to look at the potential impact of initiating combination antiretroviral therapy for all people living with HIV, regardless of CD4 level, because as I mentioned at the time, therapy was only recommended for people whose CD4 cells had dropped below 350 or 200, and also scaling up PrEP for uninfected but at-risk populations. So the modelers concluded that doing these two things, sorry for that, it's a little bit blurry, but early initiation of ART and PrEP for the uninfected, if we really scale that up fully to populations, the modelers said that in about 10 years, we can bring incidence to levels low enough to start to bring about the end of the epidemic. This then led to a whole worldwide mobilization to focus on bringing an end to the HIV epidemic, which is no small feat, however. to place us and remind us of the numbers we're dealing with. We have between 31 and 43 million people living with HIV globally, with the highest concentration in sub-Saharan Africa, followed by Asia and the Pacific, and Western and Central Asia, and you can see the numbers for the rest of the globe. Back home in the United States, we have an estimated million-plus people living with HIV. At the end of 2016, the rate of adults and adolescents living with diagnosed HIV infection was 367.6 per 100,000 population. But we know that the number is even higher because of people actually who are not being diagnosed. The highest concentration is on the East and West Coast, you can see, and also in the southern United States, where clearly where people are really starting to pay attention here because incidence is actually rising in some of these areas. And if some of you have also heard about some of the outbreaks with the opioid epidemic in Indiana, and we're expecting in Kentucky and places like that. So it's also worth noting that 1/3 of people living with HIV in the United States reside in New York State. So this brings me to our local New York State Ending the Epidemic initiative. Governor Cuomo appointed a task force in the fall of 2014 to develop a plan focused on 3 important goals. Those goals were identifying persons with HIV who remain undiagnosed and linking them to health care, linking and retaining persons with HIV to health care, getting them on antiretroviral therapy to improve their health and to prevent onward transmission, and providing PrEP to high-risk persons to keep them HIV negative. Several of us from the HIV Center, including myself, served on this task force, which also included other academics from New York State, community, and other stakeholders, medical providers, and policymakers. Within 4 months, it was very intensive. Within 4 months, we developed a blueprint, recommendations for ending the epidemic, which addressed prevention, care, and supportive services. And a few of us made sure to include specific recommendations about the integration of mental health and substance use services into all HIV care settings. In April of 2015, the governor publicly announced the blueprint and the commitment of funds and some policy changes to become the first state in the country to make a commitment to end the HIV epidemic. A smaller group of us continue to serve on an Ending the Epidemic Advisory Committee in the Governor's Advisory Council for the state. We are tasked with supporting the implementation of the blueprint recommendations, evaluate their success, and to modify the plan as needed. So what will it take to accomplish the goals of ending the HIV epidemic? It's very much about scale-up of treatment for people living with HIV and scale-up of PrEP for those at risk for acquiring HIV, overcoming population health disparities, addressing structural individual level barriers, and very importantly, addressing mental health and substance use. This is where many of us are focused in our work and will be the focus of the remainder of this presentation, that is addressing mental health and substance use in the HIV context. This depicts where the HIV field is at in terms of medical and behavioral care and research. It's very much about testing people. A lot of people still refuse to be tested, but testing people, diagnosing either HIV negative or positive, screening and considering PrEP for those at risk, but definitely initiating ART, and we're now in the era of immediate ART for people when they find out doctors are saying we don't even need to look at CD4 cells. If we diagnose HIV, we want to give treatment right away. And the science shows that that's a benefit to the individual in terms of long-term health. It's also a benefit to the population because it prevents onward transmission once they're suppressed. So getting people into primary care, which is both for negative and positive, because even if you're taking Truvada, you're taking PrEP, you need to be in medical care. You need to be seen regularly, every 4 months at least, for HIV testing, but also testing for potential toxicities, kidney function, and things like that. But keeping people in care, engaging them, adherence, retention, all leading to prevention of HIV acquisition, and for the negatives, virological suppression, all reducing HIV in the community towards this notion of actually ending the epidemic. But we have solid evidence that mental health and substance use influences every step in this cascade. So let's take a closer look at mental health and HIV prevention. Mental illness indeed is a risk factor for HIV acquisition, as you see, for example, the consistently higher HIV incidence among people with serious mental illness compared to the general population in the United States. And when you have comorbid disorders and other conditions, there is a synergistic effect on HIV outcomes. For example, here you see among 4,000 men who have sex with men across 6 U.S. cities, when there are co-occurring conditions such as mood disorders, substance use, and prior experience of childhood sexual abuse, the probability of staying HIV negative goes quite significantly down as the number of these conditions increase. And in the context of PrEP, we're beginning to see that scale up of PrEP depression is associated with higher sexual risk behavior and poorer adherence, thus indicating that screening and treatment for mental health problems may be important to maximize PrEP efficacy. Let's take a more closer look at people living with HIV. Here you see the rates of each of these disorders are considerably higher among people living with HIV compared to the general population. Drawing your attention to the large disparities for lifetime alcohol or other substance use disorder, lifetime PTSD, and current depression. Here's another table looking at the range and prevalence of psychiatric comorbidities among people living with HIV and people in HIV care, including the high prevalence of cognitive disorders, pain, and insomnia. This is data from Claude Mellon's longitudinal cohort of perinatal infected perinatal infected and perinatally HIV exposed but uninfected youth. They were originally recruited between 2003-2008 when the youth were 9 to 16 years old from 4 major medical centers in New York. You can see the cross-sectional rates of psychiatric disorders in this population. The prevalence of these disorders in Claude's study of CASA are similar to those found in the US and international studies in Africa and Asia. And when she looks more closely, these cross-sectional snapshots do not necessarily capture developmental burden of mental health problems in this population. Here you can see that cross-sectional snapshot that we just looked at in the prior slide significantly underestimates the impact of mental health on young people during adolescence. For example, over 83% were diagnosed with at least one disorder, with 53% being diagnosed with 2 or more disorders over time. So you can see the rates, and you can see the other rates for the other specific types of disorders. So cross-sectional is going to underestimate, but this is a vulnerable period of time in youth and adolescence and young adulthood. So why the high burden of mental health problems in the HIV context? Much like other populations that many of you work with, people coping with mental illness, and particularly serious and chronic mental illness, other conditions and other situations that can increase stress and distress in their lives and exacerbate or even cause mental health impairment. In the context of HIV, it is definitely true that there are influences from multiple domains, including political, social, economic, physical environments, operating at the macro and micro levels. All of these factors can influence HIV and mental health comorbidities, including demographic factors, biological, community, environmental, psychosocial factors. I'd like to particularly point out the intersecting stigmas that many people face in this context. Stigmas that, unfortunately, HIV stigma remains very powerful. It's maybe not quite as dramatic as I showed you in the pictures in the very beginning of the epidemic, but it's still very powerful, locally and globally. On top of that, there's the stigma of mental illness. Stigma for some people being of gender or sexual minority status, or racial identity minority status, or being a person who uses substances or engages in sex work. So you've got these intersecting stigmas that our populations are dealing with. And I'd like to add that even in the absence of a diagnosable mental disorder, there can be a great deal of distress and distress associated with most of these factors, including stigma. Now, depression is the most prevalent in the context of HIV and also most studied, so let's focus on that for a little bit. Depression is associated with increased mortality in the HIV context. Among these relatively large cohorts of women followed over time, depression is associated with 2 to 3 times the risk of mortality compared to women without depressive symptoms when on ART, and as much as 7 times the hazard of mortality in the absence of antiretroviral therapy. Thus, while therapy is most certainly protective, even when controlling for duration of ART use, CD4 count, and age, depression still doubles the risk of mortality. And here we see in a cohort of nearly 6,000 individuals, the length of time suffering from depression increases the risk of mortality in a dose-response fashion. 25% increase in days of depression associated with an increase of 19% risk of mortality. So what are the potential pathways between mental illness and HIV health outcomes? Well, looking at the potential biological mechanism, we have direct effects of depression on the immune system with chronic immune activation and HPA dysregulation. We know that HIV crosses the blood-brain barrier with immune activation in the brain and the central nervous system with inflammatory proteins leading to oxidative stress and neuronal injury. Chronic inflammatory response includes elevation in the levels of cytokines and TNF-alpha, triggering a chain reaction involving tryptophan depletion through the activation of IDO enzyme. And tryptophan depletion reduces serotonin levels, increases canurinin and its metabolites, and some are neurotoxic and associated with depression, suicide, and anxiety. Now, this is not my own personal area of expertise, but it's an area of expertise of many in this department. I think it's an interesting area of inquiry in the HIV context, currently with many questions that are worth exploring. And more in my domain of expertise, I can say that the behavioral pathway between mental illness and HIV health outcomes is pretty clear. As stated earlier, mental health impairment contributes to increased risk behaviors, delayed HIV testing and care initiation, poor retention in care, delayed ART initiation, and poor adherence. Whatever the pathway, it's clear that we need to address mental health problems. We want to improve health outcomes along the HIV prevention and HIV care continua. All of these lead to non-optimal HIV treatment outcomes. Whoops. And whatever the pathway, it's clear, again, that we need to address these things in the HIV context. So to summarize, it seems pretty clear that we have increased morbidity and mortality. We have, depression and hazardous substance use are associated with increased morbidity and mortality, not initiating antiretroviral therapy, not adhering to ART once initiated, slower virological suppression, faster virological failure, and increased risk behavior. Thus, it seems pretty clear that there's a need for mental health screening and treatment in HIV prevention and care settings. Now, all of you in this audience know that we have an array of reliable and valid mental health screening tools that are being used in clinical care as well as in research, and these have been validated in low and middle income countries where a lot of our work takes place. And I don't need to convince anyone in this room that we most certainly do have effective mental health treatments, including psychopharmacological interventions, an array of psychotherapies, stress reduction interventions, and harm reduction and abstinence interventions. Many of these are manualized, some of the work out of this department, and tailored and translated across languages and cultures, capable of being scaled up. Some are using technology for this part of scale up. So what about the effectiveness of these kinds of interventions, broad range of psychiatric, psychological interventions for people living with HIV? Here I'm highlighting the 3 most recent and comprehensive systematic reviews and meta-analyses, which cover 181 studies across all income level countries with more than 20,000 patients representing all populations across this range of studies. And you can see that there's also a fairly wide range of intervention intensity and duration, as well as a wide array of intervention types. Here I'm summarizing a lot of data, but showing that what, in my opinion, are the most prominent findings of these reviews and meta-analyses. We see on average moderate positive effects on reducing depression and anxiety and improving quality of life and psychological well-being. The largest effects are with lengthier and multi-level interventions and when integrated into community-based healthcare. Interventions that are primarily focused on mental health and also delivered by mental health care professionals are most effective. Now, this presents a challenge for the HIV field since so much of the burden of HIV is in resource-constrained settings globally and even here in the United States in poorer communities. So I think all of us are dealing with a push towards briefer interventions and in the global context, the use of lay counselors rather than trained mental health care providers to deliver the needed care. But again, the evidence is for greater effectiveness when interventions are delivered by mental health care professionals. So that's a challenge, and maybe we can talk about that in our discussion period. My Mark Rubio moment. The reality, though, is we have a mental health treatment gap, right? People with a behavioral health disorder, and just to be clear when I talk about behavioral health, which is becoming more common in the practice field, that's meant to encompass mental health and substance use disorders. 67% of people with a behavioral health disorder do not get the behavioral health treatment they need. 30 to 50% of referrals from primary care to an outpatient behavioral health clinic don't make the first appointment. 2/3 of primary care physicians report not being able to access outpatient behavioral health for their patients. Shortages of mental health care providers, health plan barriers, lack of coverage and inadequate coverage, as well as stigma were all cited as important barriers. So I'm going to focus a little bit on the current themes of our newly funded HIV Center, which was funded in April of this year, last year, 2018. And our theme is on the science of ending the HIV epidemic, efficacy to effectiveness at scale for global impact. Here you can see the primary aims of the center to catalyze intervention implementation science research to advance both U.S. and global ending the epidemic goals by studying individual, social, contextual, and structural factors that influence outcomes in HIV prevention and care, to translate research into culturally and structurally competent practice and policy for maximum public health impact, and to increase the capacity of current and future generations of scientists, service providers, and community and policy leaders to create and implement groundbreaking, high-impact biomedical, behavioral, social, and structural HIV prevention and treatment interventions to meet our ending the epidemic goals. And by the way, we have a very vital, important T32 program in our division associated with the HIV Center, led by Theo Sanford, with currently 7, I think, pretty amazing postdoctoral fellows. So please go to our website, read about them, read about the program, and there's potential for great collaborations there as well with our postdoctoral fellows. And also, well, I don't have time to get into it. I'm just going to mention here, because our center is beginning to study this, in the HIV field, there's a lot of work going on right now in developing and studying long-term injectables and implants for delivery of antiretroviral therapy. And the hope is this may overcome some of the problems with medication adherence, which requires daily pill taking. But those of us who are behavioral scientists, we realize that's going to come with a whole other host of implementation, access, inequalities, but also adherence, because there's still going to be adherence to whatever is needed for the long term, for the injectables and the implants. So I just wanted to put that out there. We can talk about it more. Our center remains multidisciplinary, with central leadership from psychology, behavioral health, and epidemiology, and core leadership from psychiatry, psychology, sociology, infectious disease, and biostatistics. And we have a broad range of faculty from Albert Einstein College of Medicine, CUNY School of Public Health, and Cornell, in addition to from multiple departments at Columbia University Medical Center. And here you can see that all the multiple institutional partners of our center, including the various academic centers, hospitals, clinics, and community-based organizations in the US and globally. And very importantly, our partnership, very close partnership, with the New York State and New York State Departments of Health, as well as OMH and the Department of Corrections. Here I'd like to highlight the growing body of evidence, including from several investigators in our psychiatry department, like kind of highlighted at the bottom. You can see people in our department. These are just some examples of the work that shows the benefits of integrating mental health screening and treatment into care. Of course, at the first critical step of there being screening and integration into care, essentially, if we reduce stress, distress, and mental health symptomatology, reduce substance use and sexual risk behaviors, and improve coping, we can improve adherence to care and treatment, thus increasing viral suppression and health outcomes for infected individuals and reduce ongoing HIV transmission. Very innovative work here in I think our wonderful New York City Health Department, who we work very closely with, coming out of the ending of the epidemic blueprint. The New York City DOH-MH has, first of all, changed the name of the STD clinics to sexual health clinics, which is interesting. They've been called STD clinics for forever. Now they're called sexual health clinics, which alone is making a difference in how people view these places and their willingness to come there for services. And the health department, in collaboration with HIV researchers, developed a conceptual model of HIV status neutral prevention and treatment cycle, where those at risk for HIV acquisition move to the left and those at risk for HIV disease progression on onward transmission move towards the right. Well, I don't need to point, you can see it. And HIV testing is the gateway for entering the system, right? And ultimately support can be provided wherever people may be on this cycle. With the direction in which people go may be different, but the goal, didn't want to go there. The goal is to end up at the right place where the risk of acquisition, onward transmission, disease progression is minimized. Further, we are working in collaboration with the health department to integrate screening and subsequent referrals as needed for mental health and substance use problems for all people entering the cycle, whether they test HIV negative or HIV positive. And with an HIV status neutral approach, there is the potential, we believe, for reduction in stigma and anxiety and improved sexual health and overall well-being. Some of you may be seeing these U equals U ads on the subway, undetectable equals untransmittable. I actually took this picture of a friend and colleague from the task force, Peter Staley, saying, I can't transmit HIV to anyone anymore. This U equals U campaign is a media-based and community-wide intervention which emanated from the community and is definitely supported by the science. Tony Fauci and other NIH leaders have endorsed this campaign for the past couple of years. And just last week, it was noted, I just wanted to note that, I'm using the wrong, for those of you who can see down here, just last week, it was endorsed online by our director, NIH Director Francis Collins, and wrote a whole blog about it. So the science is there, the enthusiasm is there, and it's, I think, an important campaign. And it seems to me, well, that not necessarily this is an intervention to address serious mental illness and clinical disorders, but I think that this community-based intervention campaign carries promise for reducing psychological distress, as well as building hope and reducing stigma. And anecdotally, we're beginning to see that the U equals U message is making a difference in the well-being of people living with HIV and their partners. I'll just read the top quote, but it's emblematic of what we're hearing from the HIV positive community. When I learned I was HIV positive, I became isolated and depressed. I went on medication, but knowing I had the virus made me feel dirty and ashamed. I stayed that way for 7 years, stigmatizing myself. U equals U has given me my life back. Knowing that I can't infect anyone has allowed me to forgive myself. So I think it's a pretty powerful statement, and again, it's not the only one we're hearing from the community. And similarly, we're seeing the psychological benefits of PrEP, significantly reducing symptoms of anxiety and depression about the sex that people have. And there's emerging evidence that the engagement in PrEP care, particularly for young people, I think we know notoriously that young people, adolescents, and young adults often don't access health care regularly. But the greater engagement, we're seeing greater engagement in screening and treatment for mental health and behavioral health challenges, as well as screening and treatment for other health conditions, such as diabetes, hypertension, and tobacco use. So there's a lot of side effects to scaling up PrEP. I want to talk about, start to wrap up my presentation by talking about different models for delivering all services in a patient-centered care approach. So with a consultative referral model, there is often limited or no communication among providers. Thus, patients often fall through the cracks, which is one of the reasons the HIV care continuum looks terrible in many places. Co-location helps, but people still can fall through the cracks even in the healthcare systems with integrated electronic records. There's not necessarily an integrated treatment plan that's fully taking into account all the patient's HIV and mental health and substance use needs. The ideal, of course, that we all want to strive for and we're pushing for is a truly integrated care model. Now, just to talk about a little bit our Northeastern AIDS Education Training Center here at Columbia under the leadership of Daria Baca-Lattimore and Francine Kornos, with Karen McKinnon as Director of Behavioral Health, myself as Clinical Director for Behavioral Health. And there's several training faculty in our Department of Psychiatry, part of the AATC. We are still the only AATC in the country with a separate behavioral health component. This grew out of an early recognition here at Columbia and in our HIV center that mental health played such a strong and significant role in the HIV epidemic, including early research on the prevalence of HIV among those with severe mental illness in state psychiatric hospitals in New York City. So in the beginning, when we first started, it was a lot more about didactic and clinical skills training and dissemination of research around mental health and HIV and diffusion. Now it's highly focused on practice transformation, meeting sites where there are to integrate care, providing skilled practice facilitation coach to make system changes. Many of you maybe know about the DISRIP program, has been used as a way to bring medical care into psychiatric settings. Our ATC is beginning to bring behavioral health care into HIV care sites and federally qualified health centers and other kinds of primary care centers. HRSA, which of course is the funder, has asked that proposals devote a large portion of their budget to practice transformation. And for those researchers of us, this is really implementation science, and there's opportunities here to conduct implementation science. And so here we are coming full circle again in terms of time. I think a great example of an approach to mental health care for people living with HIV is the Special Needs Clinic, which is a mental health clinic for youth and families just across the street in New York Presbyterian Hospital. And there's several people here who are part of that clinic. This clinic was started in the early 1990s by two postdoctoral fellows at the HIV Center who had done their clinical training here, and that is Jenny Havens, a psychiatrist, and Claude Mellons, a psychologist. At the time, the model was very novel and rarely done in child mental health. It is one-stop shopping with children, adolescents, and adults treated in the same site. Mental health services are coordinated with medical services. Multidisciplinary services are delivered in a coordinated manner, including individual, family, and group psychotherapy and psychopharmacology, and wraparound services ensuring that things like benefits are obtained and other needs such as learning and vocation may be addressed. Currently, this is considered an effective common model in the U.S. for child and adolescent HIV care, and increasingly child and adolescent mental health care. Increasingly, this is being used. And this has been envisioned by Warren Ng, who director here at the hospital, and the multidisciplinary staff of the Special Needs Clinic, who have broadened its mission now to other chronic illnesses and who are applying this model to all care services. So this is a concept of a clinic that was ahead of its time, developed for families coping with HIV, and is now serving as a model for other chronic illnesses. And I think that's pretty amazing. So kudos to that group. I want to sort of wrap up by talking, many of us are interested in global mental health. I'd like to wrap up by talking a little bit more about the adaptation of evidence-based interventions for international settings. Many of us believe it's important to optimize fidelity as well as fit and work with our local partners for consensus building, for the balance of fidelity and fit, and of course pilot testing and the resulting interventions that you come up with, that you create with your international local partners, matching the culture where the intervention is going to take place. And I want to give you just a few examples. There are many more, but just show you a few examples of the type of work coming out of our center. This is Claude Mellon's trio of collaborations in 3 countries with culturally adapted and created interventions focused on promotion of mental health and adherence to HIV care and treatment, risk prevention, economic empowerment, all with a family-based focus. And the team is seeing positive results in all of these domains coming out of these studies. I'm going to take a little bit of time to focus on an example from my own team's work in which we developed a guided laptop-based or tablet-based multimedia intervention to enhance the capacity of adherence counselors in South Africa. These are lay counselors to implement mental health screening and deliver the adherence counseling that's required in the setting when patients initiate antiretroviral therapy. The work is being done in very crowded, very busy clinics where counselors grab any space they can to meet with patients and their patient support partners or what they call treatment buddies. The intervention, very importantly for what I've been talking about, has built-in standardized screening tools for psychiatric distress and alcohol substance use problems, with automatic scoring and a script that comes up for the counselor to make a referral depending on the severity of the reported symptoms. We use a lot of images and pictures. It's a low literacy population. This is translated into the local language of Xhosa, but you're seeing in English here. People identify their barriers to medication adherence, use of pictures again. And we have interactive activities that patients and the counselors can engage in. This was created with the local, I don't know if everyone in the back can see the bottom, but this was created locally, a pictorial image and an interactive image of what it means to adhere. And what they came up with the metaphor of climbing a mountain, being active, mobilizing yourself to adhere. And you probably can't read this, but what happens here when they change the adherence toggle, viral load, if you start to adhere, your viral load goes down, illnesses go up, your CD4 goes up, and the person looks healthier and more robust. You play with this, and if the adherence goes down, the person starts to go underwater. They start to drown. The image actually becomes thinner and looks more ill, and you'll see that the viral load will go up, which leads to CD4 drop, which leads to opportunistic infections. So it's really fun for them, not fun, it's interesting for them to play with. They kind of get the message. And what we see is patients are talking with their providers, or even the pharmacists are referring to the metaphor of you don't want to start to drown, you don't want to get sick. So just an example of cultural adaptation. And also the use of technology. So we also embed in the intervention, there are videos which show patient and a friend problem solving barriers to adherence, or a family member helping support adherence. So it really, the counselors really like it because they get to sort of click buttons and show these things that are very powerful messages for their patients. And finally, for something a little different, but I think very innovative, Ruben Robbins in our department and in our division has developed an app to assess and screen for neurocognitive impairment. Ruben had a poster about this at yesterday's Celebration of Science event. Maybe some of you saw it. It's a relatively brief screener that is completely self-contained, highly automated, highly portable, and provides immediate results. And he's conducting several validation studies across cultures with great success. So that's why I bring it in here, because he's now working in different countries, translation to different language, and the hope is that this can be a relatively brief, user-friendly screener that doesn't require all the bells and whistles and stopwatches and all kinds of things to do in neuropsych. But the screening, and like I said, he's seeing great success in terms of its reliability and validity compared to gold standard measures of neuropsychological assessments. It can be used more broadly. Jeff asked if it's specific to HIV. He's been doing this work predominantly in the HIV context, but he's also studying uninfected people and has done that. And you can ask, Ruben's here, I think, and he can talk about it. But yeah, no, the applicability is definitely beyond. The reason, though, that we are using it in the HIV context is because of the cognitive impairment that is associated with HIV disease, but of course that's true of other diseases. So my take-home message is that I hope I've convinced you of some of this, that mental health problems ranging from distress to serious mental illness are elevated among people at risk for HIV and those living with HIV. Mental health problems contribute to HIV acquisition and poor outcomes along the HIV treatment continuum. We have the necessary assessment, screening tools. We have efficacious treatments. However, we need to prioritize mental health treatment with appropriate resources to address the current gap. Integrating mental health assessment and treatment into HIV care should be routine and is essential to achieving our ending the epidemic goals. Cultural tailoring, because we need to go to environments and places where HIV is the high HIV burden. But again, this can be applied to other health conditions. But cultural tailoring is essential to successful integration in global contexts. PrEP Scale-Up and the You Because You campaign that I talked about provide opportunities for significantly improving well-being and quality of life for people at risk for acquiring HIV and those living with HIV. We need, I'm talking to the choir here, but we need stronger advocacy for the human right to the highest attainable standard of mental health across the globe. For we all know there's no health without mental health. And I'd like to really end on a note of the synergies and opportunities for collaboration across our department. And I think there are many. Certainly for any of you not affiliated with the HIV Center, you see the breadth of work we do, please visit our website. There's potential for collaborations and partnerships between HIV Center faculty and other faculty here in the department, but also in our Columbia University Global Mental Health Programs. This collaborative network of programs across Columbia University that is very active right now, under the leadership of Kathy Pike and including people, many in the room, Myrna Weissman, Ezra Sussa, Jeffrey Reed, Milton Weinberg, Christian Duarte, Linda Verdali, Claude, myself, many others. Sorry if I haven't mentioned you and you're here. I think there's potential for some great, particularly with the focus on global mental health that many of us believe in. So I hope we can work together towards greater innovative collaborations and partnerships across our department, as well as across the whole Columbia campus. So let me close by acknowledging the many people who helped provide input into this presentation, including the sharing of some of their data and their slides. And I really thank you for being here and thank you for your attention.
Robert, thank you very much for that presentation, which unfortunately I only caught the last part of. I'm going to have you do a command performance later on today. But it's hard to overstate what a remarkable record of both research, scholarship, and also just human service that the group that began 30-some years ago and has continued to now, with not only consistent success, but increasing success. And there's a Yiddish expression called nachas, when you feel proud about what somebody's been able to accomplish. And that's certainly what I feel when I hear about this.
I showed this early on, Jeff.
Anka would be here today, but she has a family-related illness thing. So let me just ask a question somewhat naively. HIV is one of the great success stories of medicine in terms of addressing a public health epidemic. And despite the progress in terms of treatment, in terms of management, in terms of clinical services, awareness, there's now some kind of recidivism where instead of being eradicated or continuing to go down, it's either staying constant or increasing because of complacency or lack of adequate services. And the effort has shifted from the basic research in pharmacology and virology to behavioral services to a large degree. Now, in some ways, it parallels what we've seen with tuberculosis, where it's gone, but because the compliance, the availability of services don't, hold up, there's continuation of something that should have been eradicated, and we see it with other conditions as well. So that's the first part. Is that pretty much accurate? And then secondly, what AIDS did, beginning, in the late 70s, early 80s, was to mobilize advocacy outside of the box of any special interest or disease advocacy group ever did historically. And it was a stunning success. The epidemic began in the late 70s. In 82 or 84, they isolated the virus.
83.
83, they isolated the virus. 87 was AZT, the first treatment. And in 1992, Magic Johnson announced that he had AIDS, and he's now president of the Lakers. But the services are still lacking.
Right.
So is it possible, since they're lacking in all of healthcare, mental health care included, is it possible for the same kind of energy and of advocacy to be resurrected to impact the service delivery and as it did originally the research?
Okay. So you had a ton embedded in your comments
Well,
and
just
questions.
two basically, but
yeah.
you can talk about whatever you
Well,
want.
first of all, I mean, you're fairly accurate in terms of the way you depicted where we're at in terms of being able to treat the disease, although there still is basic science going on. We still don't have a vaccine, and there's still a lot of work out of NIAID for a vaccine. Tony Fauci feels like he still wants to find a vaccine. There's also cure research, because it's not cured. It still requires lifelong therapy, right? And you didn't hear me mention that besides the pill taking, there's now work on long-acting injectables and implants. But again, as you point out, all of those require behavioral components as well as access. Part of the thread of my talk was also about the stigma that's still associated with the disease.
It's also the high-risk sex.
Well, we have the tools where I would challenge that to say that we've almost eliminated what you are labeling as high-risk sex. Because
I mean, unprotected.
well, yes, but even unprotected sex, because we have these tools, which was part of my premise, right? We have PrEP, which is a pill a day that if someone takes it who is uninfected and they adhere to it, even if they are exposed to the virus with unprotected sex, they will not get infected. They are protected. It acts like a vaccine, but it's not a vaccine because you don't get it and then you're vaccinated. You have to take the pill while you're in HIV risk situation. So some people, for instance, we call seasons of risk. Some people are mindful of, I don't have sex all the time, or I only have a monogamous partner who I know is HIV negative. But if someone is in a risk arena, that will protect them. The converse of that is the person living with HIV, which is why there's such a push to test everyone. New York State even changed their law about medical testing in medical settings. Test everyone and immediately initiate antiretroviral therapy. Because once someone brings their viral load down to a suppressed level, they are uninfectious. This is what Francis Collins just endorsed last week online. Tony Fauci did it a couple of years ago, where the science is there. Full suppression, and it's not hard to achieve. We have very, very potent combination therapy. So you have full suppression, so you have protection on both sides. A positive person with a suppressed viral load cannot give that virus to anyone. And then the negative person, they're not going to get it. They don't have to take PrEP with that person. But if there's someone else out there who doesn't have suppressed viral load, they can protect themselves with PrEP. So that's why we're talking about our ability to end the epidemic, because these tools, if you really implemented these at scale, you would bring incidence down well below 0.5, which is a level that will end an epidemic, right?
Does the same hold true for that study that Mike Henderson did with pregnant mothers with protecting the fetus?
I'm not sure specifically which study you're talking about, but the fetus is definitely protected when a mother has suppressed viral load, when she's on treatment. So we've also conquered mother-to-child transmission. I think we've had 0 in this country, or 1 or 2 in this country, mother-to-child transmission. Now, not everyone is accessing the treatment in all of sub-Saharan Africa, so there's still efforts around that. I think the other large topic you brought up was the mobilization and community mobilization. Was that, and that That is so true in the HIV field. I mean, the activists early on were just, I think, Peter Staley, whose picture I showed in that Subway ad, was one of the people who, who stormed the FDA and the NIH, and of course ended up becoming friends with people like Tony Fauci, but was really, 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 really pushed for treatment. So there was a quick response in spite of the politics at the time, and people would say Ronald Reagan and our president, people who were not dealing with HIV and ignoring it, the community push. I mean, that happens in the mental health community, that happens in other communities. But I'm actually forgetting there was something else you were.
I was just saying that is the same kind of energy and innovation and advocacy able to be resurrected to expand the scope of services so that
Yes.
they approach what would be the ideal?
Yes, and that's what particular there is. I think there is worldwide, and it's why I touched upon global mental health. Part of the premise of this entire presentation is that addressing mental health and substance use is key to ending the epidemic, because that's what's preventing people from accessing, adhering, taking care of themselves. So there is a push out of the blueprint from the New York State Ending the Epidemic Initiative, from the governor's office and those of us who are on the task force. Out of that blueprint is a real push for a lot of community mobilization still. The services needed. One of the biggest the biggest effect we can have on the epidemic anywhere, but we're doing it in New York, is housing, dealing with homelessness. So there's change now. We're providing housing for people living with HIV. That's making a big difference in terms of people accessing and being in care. So, and the ramping up and integration of not only mental health and substance use services, but other kinds of, think about all case management kinds of services. So there is still, I would say, and other people in the room can comment as well, that there is a lot of mobilization around ending the epidemic. I mean, that is a thing that communities, locally and globally, are really pushing policymakers and service providers to say, we can do this. Let's do it in our community. And that's why I showed the picture and quote of Governor Cuomo saying, we're going to be the first state that's going to end the epidemic. And so there's, you need political will, you need the resources. Millions of dollars are going into initiatives in New York State, some of which I mentioned, that are implementing this blueprint that says, if you do this, we can really bring it down to even more than incidence below point. People are saying we can bring it to zero if the will, the resources, and the energy is there.
There's a saying which is axiomatically believed to be true, but isn't. The world, if you build a better mousetrap, the world will beat a path to your door. So here you've got, I didn't even realize the extent of the preventability options that existed, but you have the means to not eradicate, but contain to zero a previous scourge that was an epidemic. And we're just not taking full advantage of that.
Exactly.
And that's so true in so many different instances in healthcare.
Yeah.
Other questions? Yes, sir.
Thank you so much for that great talk. There's so many thoughts that I have. I'm going to limit it. But one of the biggest things that strikes me about all of this is thinking about kind of identity, right? Who's the identity of the individual who is either at risk of HIV transmission or maybe has the virus? And part of me thinks this, thought that I have, that it's so much easier to have sex than it is to talk about it. And when I'm thinking about that is I want to know, you have a room full of psychiatrists or clinicians, and I'm thinking if we can kind of go back to the very beginning or, prevention, even without PrEP, how comfortable do you think that psychiatrists are, or psychologists, whoever, talking about sex with patients? And because I think that in many ways, it's not only sex, but it's substance use. And what do we need to do to improve kind of not only screening tools, but also questions to be able to broach some of these topics that people don't even feel comfortable talking with their friends about? How can we better ourselves?
Right. Great thoughts and great questions. And I think you're right on about the need for, I would hope it's true when I say I think psychiatrists, psychologists are a little more, a little more comfortable than other primary care providers about talking about sex, but still not fully comfortable. And I think some of it goes back to training, normalizing and sensitivity training, but I think the big thing is normalizing sex and talking about it in just a very normal way, as you do about, if doctors, I'm going back to MDs, but they ask about your diet or do you exercise, why shouldn't it be very natural to say, and tell me about your sex life, are you satisfied with it? Are you having sex with men, women, or both? Or, normalizing it, being comfortable. So I think there are a lot of providers in this room who are comfortable with it. I think some need to be more comfortable with it. I'm not involved in training of of residents and whatnot, but I think that, and we do have, actually, we have some programs here where we do have courses for residents around sexual health. And even my comment about the New York City, I think the culture can change, right? Just changing the name of STD clinics to sexual health clinics. And it's really about promoting well-being in a sexual positive way, I think. And I think there's room for some cultural shift.
I think it's largely an issue of training. If I go to see a urologist, after my prostate procedure, he has no problem, or she has no problem talking to me about that. It's just, I don't want to go into medicine. I can't stand the sight of blood. And then, you spend your first month on a surgical rotation, and, you can see anything and not faint. So it's just training. So there's a Victorian prudish attitude. Although I do wonder whether the Me Too movement is going to have any kind of bearing on the facility in which training and application of that is done. Yes, Milton. There we go.
Bob, you were fantastic. You were able to do 35 years and 400 years of stigma in an hour, and we laughed and we enjoyed your talk, and you talked very much about the reality that we don't know any of these things that they're already available, and they're so important for all of us to know because we treat patients and they are sexual beings, and talking about sex, it's much better to have sex than to talk about sex, right? And people are having sex, and actually that's part of health life. And Jeff, you just stole my comment, which is we in the training era of we need to be very well trained and to train others, to educate others about sexuality, eroticism, and prevention, and using these. And how do we do that in a Me Too era? And I know it's very difficult to answer that question because we're still in pendulums going back and forth about what we're going to do about that. But it's a very complicated matter that we need to address in training of medical students and definitely within psychiatry and psychology and social work.
Mm-hmm.
Yeah, it's also, apart from, this particular reason, it's a part of a side effect assessment as well as a diagnostic assessment. But, if you look at the thoroughness of a history and examination, you'll probably find, that sexual history or sexual activity is probably the, area that's most omitted. Genital urinary is probably the most omitted. And so it is a... Yeah, so I don't know, Melissa, is that addressed in any of your ADPERT curricular, or where's medical, where's Janice? Janice, is that addressed? Probably not, but you can speak to it if you want to or not. Melissa first.
I will definitely say this is something that's been on our radar, that we do think it's incredibly important for trainees to learn how to talk to their patients about sex and to be able to talk to their patients about sex. And we've been aware of the growing kind of Me Too movement in terms of how those conversations could feel threatening to patients, could feel threatening to trainees, just in terms of the activation that happens in those kinds of conversations. So we've partnered with the Title IX office at Columbia, at the undergraduate campus, to come here. She came here probably a month ago and did a workshop with us on specifically this issue of teasing apart sexual harassment and, being able to supervise and talking about sex in a way that can be comfortable to trainees and patients. And I thought the feedback was really very positive, and we've been talking about continuing that conversation or perhaps having her back for a grand rounds.
Also, to put a plug in for Claude Mellon's rounds coming up. It's not quite exactly, but she's talking about sex on college campuses and sexual harassment and things like that. So that's a related topic that we need to talk more about.
Janice?
In the medical school, it's certainly covered in communication courses. It's not specifically covered in the psychiatry curriculum. Though.
Yeah, I don't want to, yeah, I'm going to, one second. I don't want to, create a false sense of concern, but one can envision that if we're encouraging through training and otherwise thorough exploration of gender or sexual activity and functions in relation to clinical care, and you're supervising people. I mean, how do you distinguish probative inquiry from prurient, vicarious, whatever? Again, I don't want to erase something, but it's just something to be considered if we really want to be moving people towards a more thorough comfort level in terms of evaluating this important dimension of activity for diagnostic and treatment purposes. So
I would just simply repeat the word normalized. I mean, you ask about your stomach and your eating and if you have pain, if you have, you get headaches, do you think recreationally that are dangerous or not? And sex can be one of those topics that you just normally talk about.
Yeah, but it's different if I ask you about, after you eat, do you have heartburn? Is it upper or lower abdominal? Does it go away with food or something like that? And when I talk to you about how sexually active are you, do you reach orgasm? What kinds of activities?
Yeah, but I guess I'm suggesting that could become a normal part of a doctor-patient conversation.
All right, I'm done. Before I get myself in trouble.
Thank you, first of all. I was wondering if you could comment on kind of...
Put it up, the microphone's out.
Hey. Yeah. Wondering if you could comment on what happens to discussions of stigma as there's this kind of parallel emphasis on eradicating HIV.
Yeah.
And certainly no one would suggest not treating HIV or not trying to do everything we can to have a world free of HIV and to reduce transmission. But I wonder whether there's the kind of phenomenon that you see in other diseases where there's a community of people who've been living with this disease, and as it kind of goes away and as less people are dealing with it, it makes it almost more difficult for the people who are still challenged with it to thrive and to not feel stigmatized.
Yeah, no, it's a great question. It's a great point. It makes me think that I've seen clinically where people who are becoming infected today feel much more personally stigmatized and feel like, well, in the beginning, there was a lot we didn't know, and people were infected when, before the virus was discovered and things like that. But now that we know it, people say, God, people must look at me like I'm really irresponsible because in this day and age, because we have protective things, how did I become infected? So there's that problem. The U Equals You campaign and that coming from the HIV positive community, that in part from that community they talk about destigmatizing themselves and also trying to destigmatize themselves in the community, saying, yes, I'm living with HIV, but I am not of danger to you. So that is a movement to address that level of stigma. It's being played out differently in different environments and different cultures and different, there is a global effort to use that campaign. But unfortunately, the virus, HIV still carries stigma, and whether it's with families, and because it's transmitted through sex or needle sharing, right? So you disclose that you have HIV, that means you've been, I'm going to use this word deliberately promiscuous, or doing something else I shouldn't have been doing. And it's less visible in the streets. It's right. Those of us who were around the early days of the epidemic, it was out there. People had a lot of compassion for people dealing with illness. Now that we don't see it, we don't see it in the media as much. We don't see it depicted in movies or films as much because it's not the illness, it's not the compassion that we're seeing a lot of. I'm not sure if I'm addressing your question, but it is a challenge of the numbers of people and the people. But there is still, and the same thing on the PrEP side, right? When PrEP first came out, there was a lot of talk, and there was this label of being a PrEP whore, meaning you're taking this medication because you want to go around and have a lot of unprotected sex with a lot of people. That's the sort of the notion that comes with it. Whereas that's trying to be transformed of, PrEP is a positive thing. The sexual health clinic is like, this is a good thing for a comfortable sex life where you can be less anxious. Getting away from the label of, it's about promiscuity. I think we were challenged with the same thing with birth control when that came out, right? So these things don't go away. But the community is always, and back to Jeff's question or point, the community is mobilized. The negative community, the positive community. That's why, and look on the subway. Look for these PrEP ads. Look for these U equals U things. I mean, people are putting it out there.
I think, HIV has, stigma has multiple contributory sources. You have issues relating to sex, you have issues relating to sexual orientation, you have issues relating to intravenous drug use. So it's contending with a lot of things. I mean, they have things like sickle cell or Tay-Sachs disease, which are associated with certain ethnic or racial groups. They're not stigmatized. So it's a lot of this social baggage that comes with it.
And mental health or mental illness.
Yeah, we're right in there.
Mental illness.
Yes, ma'am. Yes.
Hi, thanks, Bob. That was amazing. You showed a statistic that was about the difficulty that primary care providers have in making successful referrals to mental health treatment for their clients. And this is a room full of mental health experts. I wonder if there's a problem-solving work group that could come out of this presentation that you gave, if people have ideas about how to bridge that particular gap, because it's massive. What do people in the room
Question
think?
to the room. I mean, yeah.
There's a lot of online forums for people, and I think now in modern day, that's a way for people to get together. I think AIDS.org might be one where there's kind of community groups for people to connect with. But I think support groups are huge, and that's what was really big in the 80s and the 90s for people to talk. And I think that just knowing that they're not alone is really important. And then thinking about official connections to primary care, I think it'd be great if we could maybe come up with even a list for ourselves as clinicians that we can refer people to.
And Karen, though, you're asking about general just primary care being able to refer or deal with mental health care? Or I wasn't sure.
Typically, primary care folks are, maybe they can treat depression with medication, but they don't feel super well equipped to treat whatever else they're seeing in their clientele, and so they try to make a referral to a mental health care person, and they don't find that very successful in terms of the client being able to complete that care, and that was the gap that you highlighted. So I was just curious. I mean, I love your idea, sir. That was amazing to hear that people might be mobilized just from, hearing about this need to be a recipient of a referral from a primary care provider. But the care is still very siloed, and I think we need to problem solve around how to make those treatment recommendations and referrals successful, rather than just sending people off and not having a good follow-through.
Claude?
So I think Karen's point is, first of all, that was fantastic, Bob. But I think this actually does speak to how siloed we are, because I think in psychiatry, and this is part of Bob's reaching out to psychiatry for more collaborations, I think things are happening in other domains that don't necessarily make it across. So if Randy Auerbach were here, he would talk about, internet-based CBT, which is now being used increasingly to deal with the mental health gap on college campuses, for example. And other people might talk about some of the linkages that are there in substance use. But I think Karen's comment is that maybe if people from different areas of psychiatry with us, and with primary care people, began to problem solve about the different things people are using, we might actually be able to take some steps forward. I think it all speaks to a dearth of mental health providers, but that's a whole nother topic.
Well, this is going to be the last comment because it's a real downer. We're talking here like we're in an ivory tower or a bubble. I mean, the healthcare system is so fragmented, so dysfunctional, so unyoked to an enlightened, coherent public health strategy that, yes, we do need these things and we will try to enact them, but it is just a monumental task to overcome the macro environmental and infrastructural and systemic problems. So, I don't say we're masochists, but we're not deterred by daunting challenges, but we can't underestimate them either, which is why one of the things we're emphasizing in terms of career development paths for trainees is, in addition to the usual research and clinical care and education, is policy.
Yep.
Robert, spectacular. I'll just take it on their word, and we'll have you do it again soon. The thing is.